Good morning, everyone. Good morning. Thank you. That's for that piece of audience participation. Thanks to Laurie for the introduction. I think of all of the introductions I have ever had, that was easily the most recent. It's great to be here in South Carolina. I guess the first thing we need to address is the accent thing. Because you all speak really funny. So as Laurie said, I'm with the Institute for Healthcare Improvement. I've been there for about 18 months now. But before that, I was the Chief Executive of Scotland's National Health Service. And so this is where the funny accent comes from. This is just the way we speak over there. And some of the stories I'll tell you during the course of the morning will go back to my time as the Chief Executive in Scotland. And I want to take as my theme for this morning this notion that and is the new or. That we need to think differently. If we are really going to transform healthcare, if we really are going to move forward and make patient care as safe as it can be, if we're going to reach unprecedented levels of performance in healthcare, and we're going to try and improve the health of the populations that we serve, then we need to have some new mental models. And one of them is thinking about this notion of and is the new or. And this really comes from work that Jim Collins and his colleagues did many, many years ago. And he described what truly visionary companies were doing. They embraced the genius of the and. They thought about continuity and change, about stability and revolution, about their heritage and about that continuous renewal of their purpose and their commitment to the people that they serve. And as my colleague Maureen Bizignano and I went around the country and around the world, indeed, finding successful organizations, we saw this. We saw the organizations who were successful embracing Jim Collins' notion of the genius of the and. And where we saw them struggling, we saw this. We saw or thinking. People taking polarized positions and making painful and often false choices between things that actually weren't a choice at all. Because, of course, you can't choose between the short term and the long term. You shouldn't choose between cost or quality, or clinical care or administration, win or lose, me or you. We can't think about innovation or marginal improvement, incremental improvement. And so one of the things I want you to think about is this bit of advice that Dilbert gives us here. And every time you hear this notion of absolutes, just be careful. Because, of course, it's not the case that every incremental change that we make should force people to make a choice. So beware the absolute in everything we do. And so we've been thinking a lot about this in IHI. We've been crafting our strategy for the future. And this is our attempt to capture that strategy on a page. This is our napkin strategy, if you like. Everybody should be able to draw their business strategy on a napkin, is my theory. If you can't draw your business strategy on a napkin, then you need one of two things. You either need a new strategy or a bigger napkin. Often it's the former. And I want to take us firstly to the intersection of those two big blue circles. That's what they say. This is what IHI is committed to doing with all of the organizations that we partner with across the world. We want to accelerate the pace of improvement in healthcare, and we want to innovate and partner with organizations to improve health. And one of the things that's particularly meaningful for us in the partnership that we've had over many years with the South Carolina Hospital Associations and with you folks here in South Carolina is that this is one of the places we get the chance to do both of these things together. And it's a path down which we aim to continue. And it's the first of my 4 ands to thrive in this new environment, in this transformation that we're just about to undertake. And I think this is tremendously exciting time to be in healthcare. It's probably the most challenging time to be in healthcare. If you think about all of the changes that we're all having to deal with, it's incredibly challenging, and we should acknowledge that. But the opportunities are also, I think, unparalleled, because these changes that we're all facing are the same changes for all of us. And so the opportunities for us to learn from each other have never been greater. The opportunities for us to create a national and international learning community who can work their way through these issues with the patients and families that we serve has never been greater. And so this is, I think, an unparalleled opportunity for us. And so one of the things I want us to think about together this morning is this notion of how do you improve healthcare and improve health. So let's start with the healthcare piece, and there we've got some things that we should celebrate. We're making progress in a number of areas. This is data from ARC that shows reductions in harm, some avoidable expense, and fewer than expected deaths. It's great progress, and we should acknowledge it. However, there's a lot of work to do. I don't know if any of you saw this reporting just a few weeks ago about the prevalence of C. difficile in the community, much more common than we thought, and many more incidences in our hospitals than we were aware of. And this is just one of those factors, I think, that's going to require our continued vigilance. It's going to require us to focus on accelerating the pace of improvement in the work that we do. It's also something that a few years ago in Scotland we had to tackle. If you look at our data there for back in 2007 or so, 7, 8, we were doing pretty poorly in our hospitals. So this is the rates of C. difficile per 100,000 bed days for the folks who are particularly at risk of it, older people. But then you can see the sharp decline in that incidence. And that was really just done by a few simple things. Well, those of us who have been working in safety for a number of years would recognize as a bundle, a set of simple interventions that you can make. It was really about hand hygiene. It was really about better isolation processes. It was about securing a cleaner hospital environment. It was about antimicrobial prescribing. A set of simple things that we always knew how to do them, and we'd never done them reliably. The interesting thing for me was that at every stage of that process, as we started to make those declines, people would come to me from the field and say, "That's it, Derek. That's the irreducible minimum now." And it was never the irreducible minimum, at least not yet. And I'm pretty sure, actually, that's not the irreducible minimum either. There will be always more that we can do. But just by those simple processes, that's an 82% reduction in C. difficile. And those are national numbers. So that's 32 acute hospitals and 70 or so community hospitals. So these kind of things can be done if we work together. But I started to learn as we were doing that work that we really needed these three things. We needed a shared and comprehensive framework. We needed to think about safety as a system. And I'll talk in a minute about what might be the component parts of that system. We needed to think about safety across the continuum of care. We needed to follow the patient with safety. And crucially, we need to engage patients in safety. Patient safety is not something that we can or should do to patients. It's something that we can and should do with patients. And we can learn a tremendous amount as we do that. So let me just touch on some of these things. When I talk about a system of safety, this is really what I mean. And this is a kind of complicated slide, so let me just spend a little bit of time talking about it. These are the building blocks, if you like. the bricks that we need to put in place in order to make care safer. And the grey bricks are the infrastructure that we need, the technical things that we need to put in place. We need good measurement. We need a learning system. We need transparency around the data, and we need reliable process. The red bricks are the social pieces, because a system of safety needs to be a social system. It needs leadership, it needs communication, it needs accountability. It needs us to pay some attention to the culture of safety and the psychology of safety. And it needs teamwork. And we need to put the patient in every conversation that we're having about every component of a system of safety. And I don't know, maybe the leaders in the room can put their hands on their heart and say, my system does all of these things for every patient, every time. But I certainly know as a CEO, I could relatively rarely say that I had that level of comfort. It took us many, many years to build a reliable system of safety. And my suspicion is it will take all of us a lot of time and a lot of effort to build this, but it's worth the building. I got a chance about a year ago to take a group of leaders to NASA to see the thinking that they were doing about building a system of safety in the aeronautics and space industry. And this is a very busy representation, but it's something I took with their permission off the wall in NASA. And it's all over the place, everywhere you go. In the offices, in the labs, on the huge warehouses that they have, you see this, it's ubiquitous. And it's their story of their system of safety. It plots every stage in what it takes to get a vessel into space. And it identifies both the potential and the actual risks that they've identified in doing that. And everybody you talk to can refer you to this and can tell you about those risks along the way. And it made me wonder, could we do something like this for health? Could we follow the patient journey through self-care, into primary care, into ambulatory, into acute, and plot the potential and actual risks, and therefore better mitigate them because we were all aware? I think we probably could. IHI is actually going to do some work with NASA to figure out the transferability of some of these kind of things. And then I think the other important thing is we shouldn't see patient safety in isolation. We should see it as part of a range of concerns that patients have about their care. And when we asked back in Scotland, we asked patients about what were the things that really mattered to them, then of course being safe was an important consideration for them. It was a priority for them. But so were these other things. They wanted access to care at a time that was convenient for them and for their family, rather than at times that were convenient for us. They wanted continuity. They were tired of telling their story 10 or 12 times to 10 or 12 well-meaning professionals, and they wanted continuity. And they wanted these things that you might think are softer and more interpersonal in terms of empathy, which Laurie has already talked about, and compassion. But actually, I don't think they are. I think they're just as important, and actually there's an emerging evidence base that these things really matter. That there's a clinical benefit in kindness. That there's a relationship that can be built between a clinician and a patient that will deliver strong benefit, both for that clinician and for the patient, both for the outcomes that the clinician might prioritize and for the outcomes that the patient would prioritize. And so we need to be thinking at the same time as we're thinking about patient safety, about how do we create better access, how do we build empathic relationships with the patients that we serve. And I saw this great example of empathy. Actually, Maureen brought this back from Cincinnati Children's Hospital 6 months ago. And when we saw this clinician thinking about empathy, both in terms of the care that he was giving for the patient, but also the care that he felt duty-bound to give to the family, I think it's a strong signal of what empathy really means. So the guys are going to play the video for us.
Really considering the heartbeat as the most beautiful sound that I think is possible. And when I'm thinking of rhythm, it's our basic beats. So me using that as our foundation to create something that could preserve the humanity of a situation has been a focus of mine. The worry that a lot of families I work with, that they would forget something like the way that they feel or the touch of their hand. It's my job as a creative arts therapist to find pieces that are still successful, that are working inside of them, focusing really on that quality of life. And the songs that come out are as individual as the families.
I've looked forward to talking about this, and to me this is something in this whole process that has been positive. Brian was able to use a stethoscope microphone and record my son's heartbeat. To be able to have that and carry that around on my phone is his heartbeat. You know what I mean? I can listen to his heartbeat whenever I choose to. Our son was dying in front of us, and it was very tough. So just to hear that music, it really, really got my spirits up, and I needed that. You know, you have to go through the processes and all of the emotions that go along with it, and music is a good guide to help you through that. It is for me.
So we need to hear what matters to our patients and to our families. We need to seek that out actively, that intelligence that we'll get from asking patients and families what matters to you. And some of that will come as no surprise to us, and you will already be active addressing some of those. That's why you're committed to a symposium that's about improving patient safety. I suspect that some of it, when we ask that question, will come as a surprise to us. And we should be no less motivated to provide those kind of solutions with patients. And some of them, I think, are around kindness and compassion and empathy. So how are you doing on all of this? I pulled this from the Commonwealth Fund's state rankings. And that's a snapshot of how you're doing relative to others. And actually it looks as if on some of these things, on prevention and treatment and on avoidable hospital use and costs, the state overall is doing okay. You're in the second quartile. You're ranked about 25 on the list. You're doing okay. And that's great. And you should keep working at that. Don't choose to focus now on the things where, relative to other states, you're not doing so well, which seem to be around access and around health. So what might you do to try and move forward on health? Well, I know you're already doing many things, and that's one of the really encouraging things about coming here to South Carolina. At that breakfast we had this morning, we heard a number of stories of people committed to really making a difference to the health of people who live in South Carolina. But more practically, what might you do? Which takes me to the second piece of my accelerate the pace of improvement in healthcare, improve healthcare, and improve health. And some of these improvements in health are in our hands as healthcare practitioners and leaders, and some are in the partnerships that we're going to have to build. A 25-year-old with a bachelor's degree will live 9 years longer than a peer who doesn't get a high school diploma. And I guess you folks will know where you can find the populations who have a high level of educational attainment and where you'll find those communities that don't. And we need to work differently in those respective communities. And we'll need to pay some attention to the social determinants of health. Having said that, there are many things that healthcare can contribute to improving health. My sense is that we won't improve health in any community where the healthcare system isn't committed to that improvement. And you may only have something like 20% of the improvements at your own hands, but you have some of the other things that the community needs to generate the momentum that it will require to improve. And without your will and without your ideas, and crucially, I think, without your improvement skills, we're unlikely to see the improvement in health that our communities deserve. But I think there are a number of things that we're going to have to do as healthcare systems and healthcare leaders if we're going to make this contribution. If we're really going to optimize healthcare's contribution to the health of our populations, I think there are a few things we need to think about, and we need to be honest in our self-assessment of these things. This is partly born out of my own experience of thinking about, thinking about these things. I don't want you to make the same mistakes that I made. We need to be a better partner. Too often healthcare systems get into something of a silo mentality. We either think we can fix all of this ourselves, or we don't see ourselves as fundamentally part of the community. Unless we do, we won't be as effective as we can. We need the humility to listen and to support. The things that got us to where we've got to as healthcare leaders in particular is often having all the answers. And this is a territory where we do not have all the answers. And we need to have the humility to listen and to support. And we need to have courage. And we need to have courage that will get us started, and then we have to have courage that will persevere, because this is tough, this is difficult work. And we need to have as much courage as this guy. You like him? I showed this at the IHI offices recently, and someone came up to me afterwards. This always gets a little kind of sprinkle of laughter around the room. Someone came up to me afterwards and said, "There's something wrong with your picture, Derek." I went, "Oh, what's that?" And she said, "You would never see a penguin and a polar bear on the same ice cap." I went, "Oh, that's an interesting observation." I've got a penguin there who's carrying in its flippers a set of symbols. And there's one with a purse at the back. I used to call that a handbag, incidentally, but I now have learned to call it a purse. There's one at a purse at the back, and you think the problem with the picture is that you never see these two creatures on the same ice cap. It's funny how people's minds work, isn't it? Anyway, we need to have courage, because this is going to be difficult. And so we gathered in October of last year. A bunch of us who were interested in making progress, and IHI convened this coalition, this group of organisations who were interested in improving the health of populations. And we challenged ourselves a bit in terms of how could we get this started? How could we start a movement that would be impactful here? And we agreed that one of the ways that we should do that is by setting this huge, audacious goal of creating 100 million people living healthier lives by 2020. And that might give us the takeoff velocity, the trajectory that would get us towards a culture of health. And we've come a long way since we gathered in October, a whole bunch of us. And as you can see on the bottom left-hand corner there, a group of Latino kids with Down syndrome who told us that what health meant to them was that they could dance. If anybody's expecting me to simulate the dancing, you'll be disappointed. They were much, much better than I could ever have been. And so we have this theory of change now. We've been working since October to try and think our way through how could you get to 100 million healthier lives, 100 million people. Just think about the scale of that, 100 million people living healthier lives by 2020. And we think it needs these three things. It's going to need a level of collaboration that's unprecedented, that we've never been able to secure before. It's going to need improvement. This is where the things that you have been doing to improve your healthcare systems are going to be so important to this movement. Because it's going to need all of those improvement skills that you've got and some new ones that we'll learn together along the way. And it's going to need some system transformation. Not just in the healthcare system, incidentally, but across the range of systems that are going to have to contribute towards 100 million healthier lives. And we've been spending much of the last 6 months trying to build this thing, trying to create an identity for it, a vision for it, so that we can secure that mission. So an unprecedented collaboration trying to achieve an unprecedented result with fundamental transformation at its heart. And the really encouraging thing for us, because when IHI convened this first meeting and these first partners came together, none of the partners were really very sure about how far and fast we'd be able to take this. And in just 8 short months or so, 425 organizations have joined us in this. We've got action plans out there. We've got people who are willing to sponsor the work. We've just gone through an exercise where we invited communities to lead the work, to start the process of the actual improvement, and we got over 200 communities who said, we would like to be part of this. And we're just in the process now of selecting those 20 to 30 communities that will actually lead the work, who will create the peer learning that the other communities can follow. But some of this is going to require us to do that different thinking that I was talking about at the start. And as I was pondering how to describe to you the change in mindset that this will require from all of us, this is going to think, CEOs need to think differently, managers need to think differently, nurses, occupational therapists, doctors. As I was thinking about how to frame this for you, I thought about the guy who you can see in the picture to your right. This is a guy I used to work with in Scotland. His name is Andrew Murray. He's not to be confused with the tennis player. He's also from Scotland. He got married at the weekend, Andy Murray. But this is Dr. Andrew Murray, who was the physical activity champion in the Scottish Government. This is Andrew Murray winning the North Pole Marathon. He's the only person to win the North Pole Marathon and the Sahara Desert Marathon in the same year. He once ran 7 marathons on 7 continents in 7 days. He's a bit crazy. However, he convinced me, he said, Derek, here's the value I think I can bring you. I'm a doctor, and I'm going to be the best doctor I can be. I'm going to be the best professional I can be. If you need the kind of professional skills that I have trained to bring, I'm going to bring those. He says, but it's not enough. I'm also going to get people to think about the other doctors in their lives. And he described to me the other doctors in their lives, and here they are. Sunshine and water and rest and physical activity and exercise and so on and so forth. Fresh air and good diet. And we do have to think differently about this, and we need to be prepared to say, I'm going to bring all of my professional skills to bear on this, and I'm going to bring new thinking, different ways to think about it. And I think this next slide I'm going to show you, this will be an indication that our work here is done. When we start to see adverts on the TV, you say TV here, don't you? Television. We have that. When we start to see, do you say adverts? No. Commercials. Commercials. I'm learning the language still. I'm trying really hard. I've got better over time. But the IHI folks here will vouch for me. This is an aside. Forgive me, it's an aside. In my first days at IHI, I started to talk to them about some of my vision for where I thought the organisation was going. And we've always had a very clear, well-articulated vision. And I said, I think what we need is a route map to get us from where we are to where we need to be. And people looked at me as if, what are you talking about? And then they started to look at their feet, because they thought I meant root, as in roots that go into the ground. And I found out later that what I actually meant was route. A route map that would get us from where we are to where we needed to be. So anyway, we'll know that we've been successful when we see commercials, I told you I learned, on the television that look like this. So, the first of our 4 ands to thrive in this new world, to really be impactful in this transformation, is we need to improve healthcare, safety, access, empathy, all of healthcare, and we need to partner to improve health. So how are we going to do that? And I think here's my second and that is, I think that needs incremental improvement, it needs marginal gains, and it needs radical, audacious change. And we need to be operating at what this guy, Stephen Johnson, in his book Where Good Ideas Come From, talks about as the adjacent possible. It's right on the edge of what we know. This is where we need to be operating. And I want to tell you a story about these marginal gains, this incremental improvement, that's not from healthcare at all, because actually I think one of the things that we need to be open to is learning from outside health and healthcare. We need to be to think without boundaries in terms of where we can learn. And I want you to at least contemplate learning from the world of cycling, professional cycling. Are you open to that? Will you go with me? So you need to meet these 3 people. The guy on the left with the bald head is David Brailsford. And the guy at the far right is Chris Hoy. He's Britain's most decorated Olympian. He's Scottish. And the guy in the middle is Bradley Wiggins. And that's a picture of him winning the Tour de France. Because when David Brailsford was made the coach of the British cycling team in 2009, his guarantee when he got the job was that he would have a British rider win the Tour de France within 5 years. A British rider had never won the Tour de France. And he was saying, we're going to win this within 5 years. And people thought he was crazy. And he said, and we're going to win at least half of the gold medals at the 2012 London Olympics. He was wrong about his predictions, it turned out, because they won the Tour de France in 3 years. And they won 70% of the gold medals at the 2012 Olympics. So how did they do that? Well, they did lots of things. These very fetching pants that this model is wearing, any idea what these are? No, you're not going to have a clue. These are what these are. They are bum warmers to warm the buttocks of Olympic cyclists before they start. And the extra warmth that they get from wearing these heated pants before they start get them off the start line 100th of a second faster than their opponent. And in case you're all guessing, yes, I do have my specially heated pants on today in case I had to get off the platform quickly. So 100th of a second from the bum warmers. And then Brailsford went through everything that they did with a fine-tooth comb, and he started optimizing everything. The nutrition of the riders, their training programs, they redesigned the seat of the bicycle to give them some benefit. They designed completely new tyres that took just ounces off the weight of the tyre. But again, it made a difference. And of course, the now famous bum warmers. And then they looked at the less obvious things. So they found a pillow that helped them to sleep better when they were traveling. The most effective kind of massage gel, they taught hand hygiene to the cyclists so they got fewer infections. And then started to collect data on real time so they could make the adjustments that they needed to make every day rather than looking back a quarter or a year. Is any of this now starting to sound familiar? So these are the kind of things that we do. And they search for those tiny marginal gains everywhere, those 1% improvements. And of course, none of those improvements were significant in and of themselves. The thing that won Bradley Wiggins the Tour de France and the thing that won Chris Hoy all of those gold medals wasn't any one of those changes. It was the fact that they did all of those changes. It was the accumulation of those marginal gains that really made the difference. And I apologize to the scientists in the room, but I think this is a conversation we need to have. I think if they had done a trial on any one of those changes, they wouldn't have proceeded with it. They wouldn't have seen significance in the improvement of any one of those changes. And it was only when they started to understand the context in which the changes were being made and the cumulative effect of the changes that were being made that they started to see significant differences. And this is just our way of looking at how those small things that we could all do every day, things that you could go back and do tomorrow, small changes that if we accumulated the impact of those would make a difference. And in the end, for Brailsford and Hoy and the team, this is Hoy winning the Kieran gold medal by half the length of a bicycle. And that was the difference between success and failure for him, was those accumulation of marginal gains. So the first part of my how are we going to do this is around let's make sure that we continue to improve everything that we can possibly improve for every patient, every time. However, I think we're also going to need radical and audacious change. And this is something that we're trying to think about in the health world in the way that you've heard in this 100 Million Healthier Lives campaign. But in healthcare, working with those healthcare organizations who want to be impactful in improving healthcare and improving health, 40 or so of those organisations, including the South Carolina Hospital Association and folks from Palmetto Health, have come together in this to create this thing, the IHI Leadership Alliance. So this is 40 organisations who really want to drive the change that's needed, to be the radical renewal of healthcare in the United States. And we've been trying to, one of the things we've been doing with that group is trying to give them a collective voice, trying to enable those 40 organisations to speak as one. And we've also been trying to encourage this thinking about it's time for those organisations, for any organisation who's interested in this, to take control of this with the patients and communities and families, but not to rely any longer on the lawmakers and the political processes, because frankly, they've done what they need to do. They've given us the Affordable Care Act, which is a way of moving this forward. It's now time for change from the inside out. Less change from the outside in and more change from the inside out. And in an article that Don Berwick and myself and Saranya Laura wrote recently for JAMA, we start to describe what that might look like. And if any of these redesign principles are the kind of things that you think are important in your system, come and talk to me at some point over the course of the next day, and let's figure out whether we can work together on this, and we can make South Carolina a hotbed of this radical redesign, a place where people come to see what radical redesign can really achieve. And we think there are 8 principles for radical redesign that we really need to apply consistently if we're going to make the difference that we need to make. And these are summarized as you see here. We need to be designing systems that recognize that change is inevitable. My friend and colleague Don Berwick used to show a picture of the Cholatuka Bridge. Have people seen Don show this slide? This is a bridge that's in San Salvador. And it was right in the path of Hurricane Mitch. And they built the bridge so strong that it survived the hurricane. It was virtually the only structure that survived the hurricane. Unfortunately, the river moved as a result of the hurricane, and so the bridge now sits in a bit of dry land, and the river is about 100 yards away. We need to build systems that are responsive to change and that drive improvement, that enable improvement. And we need to think in systems terms. We need to shift the balance of power. And here we're very explicit. This is about shifting the balance of power to the patient, putting the patient much more in control. And when I speak often to managerial or clinical audiences, people get nervous about this. And I think one of the reasons they get nervous about it is that they assume that power is finite, that we only have so much power. And if I give my power away, even in a well-meaning way to patients, what am I going to be left with? And I think that's just a false premise. I think with a different distribution of power, a change in the balance of power, actually we can create more powerful systems. But we need to effect that change. Unless patients are better equipped to manage their own health, to contribute as the citizens that they in the way that they want to mobilization and activation of their health, I can't see a way for healthcare to be sustainable, frankly. Third principle we want to explore with people is how do you mobilize the pride and joy in the workforce? How do we move beyond these conversations that we're having about burnout and address them openly and transparently, address those issues because they need to be addressed, but then change the conversation to be about reconnection to purpose and what brought us all into this world in the first place. The fact that we want to make contribution. I have never spoken to a single person in healthcare who doesn't want to do a good job. So why don't we let them do a good job? Why don't we mobilize the pride and joy in the workforce? Fourth thing, we want to make the right thing easier to do. When I was the CEO in Scotland, people used to often ask me, what's your job, Derek? I don't know if any of the CEOs in the audience have ever tried to explain what their job is. But people used to ask me that question. And I used to say there's two parts to my job. The first is, my job is to make the right thing easier to do. And the second part of my job is to create an environment where people can thrive. That's the only two parts to my job. Make the right thing easier to do, create an environment where people can thrive. That's what we mean by make it easy. That the leaders need to create an environment where the right thing is easier to do. Fourth, move knowledge, not people. This is a whole host of telehealth, telemedicine, new technology interventions, but it's also more care at home and less in the office environment. It's more care in the office environment and less in the hospital environment. You get the theory. Cooperate and collaborate. It's one of the things I think you do spectacularly well here in South Carolina. Our sense is that the key to redesign will be healthcare systems working together, openly, transparently, sharing data, learning from each other. And one of the things that we're trying to create through this Leadership Alliance is a community where it's safe to do that. People feel comfortable in sharing their data and being transparent. And about the learning. Principle number 7 is about assuming abundance. It's about using all of the assets that are available to us, not just the ones that are in our hospital system, but in the communities, in our patient populations, etc. And then the 8th is about a principle that's about reducing the costs of healthcare, and we suggest in the article that healthcare costs should be no more than 15% of GDP, and that we should return the savings. We should give the savings to education so that more people can get high school diplomas and live 9 years longer. We should return the money to housing so that people don't have to suffer a barrier there. We should return the money and provide healthier food in communities so that people can live meaningful lives. So those are our redesign principles, and we are hoping that will at least stimulate a conversation about how to take healthcare forward. So that's the second of my 4 ands: incremental improvement and radical, audacious change. And that bit about the money takes me neatly to my third, which is reduce costs and improve quality. And that might seem self-evident, that of course we should be interested in reducing costs and improving quality, but I'm sure you've experienced this in the past, how easy it is for people to get wrapped up in just one of those domains. And to think that to focus all of the time, for example, on the cost savings. We had in my old system 3% target for cost savings. I shudder to think how much of my time I spent chasing that 3%. But it was certainly a lot more than 3%. And I think in hindsight, I would have been much better focusing on what am I going to do with the 97%? How can we make sure that we spend what we have in the most effective way that we possibly can? And it's not to say that reducing costs isn't important, of course it is. But you're not going to do that just by slicing 3% off, like you slice the salami in the shop. I'm not sure this is a motif that's translating well. Well, see if you can nod to me, that would help me a lot. Because all that happens there eventually is you run out of salami. So we need to think differently, and we need to get to the 97% as well as the 3%. So I need to make you feel bad for a second. Because this is an area, I think, in reducing costs and improving quality where the US has much to do. You're pretty good, actually. at improving quality. Your quality domains are respectable by international standards. And your costs are extraordinary by international standards. They're just double what most developed countries spend to get similar levels of quality. So what are you going to do about it? Well, here are some suggestions for where we might start, if I can get this to work, which isn't really, I'm not having much success. Oh, here we go. So one place to start might be to start by thinking about waste and overuse, and what costs can we take out from overuse. This is an Institute of Medicine report that was published recently that identified that a third of healthcare expenditures, $1 for every three, this is for emphasis, $1 on every three that we spend doesn't improve health. An estimated $750 billion. Just after this report came out, I had a conversation with Brent James, who is, many of you might know, he's head of quality at Intermountain Healthcare in Utah, very high-performing healthcare system. And I said to Brent, what do you think about this Institute of Medicine report? And he said, I think, Derek, the number's wrong. And I said, oh, really? Why is it wrong? It's grossly underestimated, he said. It's probably closer to half. But let's assume it is just a third. Where are we going to start? Well, I think one place to start is about reducing waste. And one place to start, if you're going to reduce waste, might be around medications. And I was on the west coast of America recently, and I heard a really impressive, incredibly well-meaning and motivated young physician talking about a patient that she was really struggling with. And the mistake she made was to ask me what I thought. And so you need to know, if we're going to continue to have conversations together, that that's always a risky thing to do, because I'm liable to tell you. And her story was thus, that she was working with this patient, and she had got in touch with the patient because the patient had been deemed a falls risk. But the thing that we're really working on was drug adherence, because this patient was on 29 prescribed drugs, but she was only taking 20 reliably. And the question they asked is, how do we get her to take all 29 of those prescriptions reliably? So my advice to her was that I'm pretty sure that if I was taking 29 prescribed drugs, I would be a falls risk. And maybe an alternative approach here would be to figure out why the patient wasn't taking those 9. Let's talk to her and find out. And secondly, to have a conversation with the patient, the pharmacist, and the consulting physician about, was there 10 of these that were actually working for her? Or better still, 5 that we could be sure she would take reliably. And she wouldn't have to bother taking this drug because it dealt with the side effects of drug number 17. And so we need to have a different conversation. And what we'll find there is better care, more reliable care, better health, patients who feel empowered and part of these decisions, and lower costs. I came across this story from Kaiser Permanente in California about some of the things they've been doing in one area of what they perceived was overuse in their system, and that's around opioids. And I know you've been doing some work in South Carolina about this too. The rate of increase in opioid prescribing over the last 20 years has just been incredible. I was really surprised when I first saw these numbers. And just as the sales have been going up, so have admissions and so have deaths from opioid abuse. And as you can see there, now the most commonly prescribed medication in the United States is hydrocodone. Such is the impact of these, what you might call the side effects of these, that drug deaths now outnumber traffic fatalities in the US. And there's been a harm as a result of this. These drugs have a street value that make them a credible alternative to heroin. Indeed, in many places, heroin is now cheaper than some of these street drugs, some of these prescribed drugs. So this is it's got bound up in a whole host of societal problems. So what the colleagues in Kaiser Permanente did is they got to work on this, and they did another of those bundles. They figured out what were the things that they could do that would really impact on this. And some of it was about protocols and clinical engagement, but some of it was also about engaging with patients and communities and figuring out what was happening in those communities. And the full results of these are published. If you want to follow this up, you can, but you can see the tremendous impact that they've had since they started to tackle this. 90% of reduction in the prescription of OxyContin in the community, significantly lower costs for them, and people feeling actually better about pain management than they were before, because they've introduced alternatives to these prescribed drugs that are resulting in effective pain management. And then one more story about the connection between improving quality and reducing cost. We've been working over the last 12 to 18 months with Harvard Business School on this joint replacement learning community. Joint replacement, fastest growing procedure in the US. And if those projections are right, you're really set to be part of our core business in healthcare for the foreseeable future. And we worked with a guy called Robert Kaplan from the Harvard Business School, who's the guy behind that value equation there. And we got him to bring what he has developed in terms of time-driven activity-based costing to the healthcare domain. And so what we were trying to do is to use time-driven activity-based costing to actually understand what every step in the process was costing, and to redesign the process. And the thing that really worked here, and the reason I'm showing these pictures, is that for the first time we got the CFO and the Chief Medical Officer working on the same projects. These are multidisciplinary teams of finance staff and orthopedic surgeons sharing in this endeavour, both working together on the project. Some of these people, before they started to do this work, had never met each other, never had a conversation, didn't have any sense of knowledge of who the person was, never mind a shared endeavour. So bringing the finance teams and the clinical teams together was really what made a big, big difference. And all of the sites were able to report reduced length of stay in orthopedics, speedier and more effective discharge, often straight to home rather than to a rehab facility, significantly improved operating room efficiency, and much lower consumables. All of them saved somewhere between 5 and 15% on their costs, and they got better outcomes. So don't make a choice between improving quality and reducing costs. Do both. Which takes me to my fourth and final, and for you to think about. And that's about thinking about how we pull all of this together for two of those populations that perhaps need our help the most. And that's people who are at the start of life and people who are at the end of life. And how can we bring together health and healthcare for those at the start of life and those at the end of life? And I want to start this story in an unlikely place, perhaps, which is in Ghana. So IHI has been working with the health department of Ghana over a number of years now, about 8 years, as you can see from the slide there, to try and reduce under 5 mortality in the country, to try and help them meet some of the development goals that the country has. And we started small. We started with 3 districts, and 2 in the northern part and 1 in the central part of Ghana, to try and test some changes that we could make, to try and really understand what would work in a Ghanaian context. And then very intentionally we're able to scale that up to the stage where by January 2013 we were reaching the whole country in that partnership with the Health Ministry. So we started there just with a few at-risk mothers and a few local communities. Again, work that you could do tomorrow. I know you are already doing work in this domain, and I'll come to that in a little while, but stuff that we could all start. Small tests of change. And the key thing that was crucial to the success that we managed to achieve in Ghana was bringing the resources of the community and the resources of the healthcare system together. And so previously, most of the births had been done by these traditional birth attendants. And I guess our original theory had been somehow we needed to shift that into the healthcare system, into the formal healthcare system, and get much more people to deliver in facilities. And indeed, that was part of our process. That was part of the reason we were successful, was that we were able to do that, including getting them transported to those facilities in a way that was novel. But crucially, what the traditional birth attendants could do is they could bring the local knowledge of what was actually happening in the villages to the conversations that we were having. And it was the participatory improvement that really made the difference, I think. And it's what contributed to that reduction in under 5 mortality rate that you can see there in Ghana. So Ghana has had a 28% reduction in under 5 mortality. Starting in 3 small districts, starting with some simple things, and then an intentional plan to scale up that used all of the assets that were available to them. And I think there are lessons for us there. I think there are some, what you might call reverse innovations that are available to us by studying what has worked in these kind of environments. And I want to tell you a little bit about something that I was involved in Scotland before I left. I'm still excited about it. And Nignon Lewis, who's in the audience and will be running one of the Triple Aim sessions this afternoon, was also instrumental in this work. Scotland is a relatively unhealthy place. Not until quite recently, one of our tourism boasts was cirrhosis capital of Europe. It wasn't really, but we had high levels of alcohol and drug-related mortality, the second lowest early mortality numbers in Europe. Despite a strong and I think highly functioning healthcare system. And we were determined to change that, to intervene in some way, to act, to shift Scotland out of that position as one of the relatively sick countries in Scotland to one of the healthiest countries in Scotland. And we chose to do that by investing in the early years. In children, when we started this from -9 months to age 3. That was our theory, was that if we could make a change in the life chances of that group of people, that's how we would change the health of the whole country. And I heard today that's at least part of what you are thinking about here too. And I would encourage you to think in that kind of way. My sense is you need to start somewhere. And I can't think of a better place to start than with the early years. And so we set this huge ambition to make Scotland the best place in the world to grow up. And frankly, I don't know whether Scotland will ever be the best place in the world to grow up, but we're going to try. And we've set ourselves some detailed goals beneath that. We're going to try and reduce infant mortality and stillbirths by 15% by the end of 2015. We're going to try and improve social attachment, again, by a given date, measured by a developmental check that we do with the child. And we're going to try and improve readiness to learn, again, by a particular time based on an assessment that we do with children. And these are the stillbirth numbers. The early signs of that, of bringing improvement science, so this brings the methods that we used to, if you cast your mind back to that chart that was about C. difficile rates in Scotland and the 82% reduction, we're using essentially the same method to do this as we applied to do that. Collaborative, peer learning collaborative. And the early results are pretty promising. Here's the stillbirth numbers. One of the changes we've had to make is we now measure that quarterly. That's probably still not enough, but we used to only measure it once a year. But we're almost at our stillbirth reduction target already. Here's the infant mortality numbers. Oh, I thought I had the quarterly infant mortality numbers. And you can see that's been more stubborn to shift. But if you drew a line along the last 8 of those dots, it would be at something like 3.7 per 1,000. And we, started at 4, and so there's some signs of some early promise. And again, all done by applying improvement science, a common method across a broad collaboration and coalition. And I know you've been making some significant improvements in this kind of area as well. And personally, I wanted to applaud that. I think this is exactly the right thing to be trying to do in South Carolina. And I'm pretty sure we could find ways of continuing that improvement. And I'm sure there are some lessons from the rest of the world in terms of how you might go about that. But this is tremendous progress, and you should be very proud of it. And I'm sure you'd also recognize there's more to do. And then, as we move towards the end of this, I want to just think about people at the end of life, and I want to frame that for you in a different kind of way, and talking about a system that we've worked with in IHI for many years, which is Jönköping in Sweden. And they were having real struggles 10 years or so ago. Their performance was okay, but not at the level that they required. And they took a very radical approach to the changes that they made. And that is that they framed it all around Esther. Esther is a fictitious patient in Jönköping, Sweden. She's 82 years old. She's got multiple chronic conditions. She needs both healthcare and social care support. She lives alone. And everybody in this audience knows someone like Esther. And the question they ask in Jönköping, in terms of every major decision that they make as a healthcare system, is what will this mean for Esther? If we make this change, what will it mean for Esther? And they frame all of their decision making around what Esther requires and around what Esther's journey is. And they have therefore understand Esther's system in a way that I think actually relatively few of us get a chance to do. And they look at things through Esther's eyes. And again, if we hark back to the video that Laurie showed us, they walk in Esther's shoes every day. And the improvements they've made are significant, but instead of showing you some of the data, I'll show you some of the international recognition that they get for this. So they are seen now as one of the most innovative, coolest places in Europe. People go from all over the world to see what they're doing in Jönköping. And it's all because and I think they would recognize this, it's all because they started with Esther. And they started with the question, what difference will this make for Esther? How will this help Esther? So you might want to look for Esther in your community. And then I think the people who we also need to be thinking about are those who are at the very end of their lives. And just to wrap all of this together in terms of what we might need to think about in terms of empathy and compassion and kindness, and asking patients what matters to them, and providing them with a quality of life at the end of their life that they deserve, improving their health at the end of life, as well as our health care at the end of their life. We could do worse than take the advice of the guy you're just about to hear from, who's a guy called Dr. Lachlan Furrow, who we call the soul doctor. Sometimes people call him the jazz doctor as well, but anyway, you're going to hear from a jazz singer also. So run the video, guys.
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with a patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Botello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess most strikingly, was that Dr. Furrow asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue.
Clouds of white.
Clouds of white.
The bright, blessed
The bright,
days.
blessed
Blessed
sun. And the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Bop, 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 bop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning.
So it's amazing what a difference a simple question, like what would make a good day for you, can make. And the thing, it always surprises me every time I've watched that video, and I've watched it many times, to see Dolly come to life just over the course of those few short minutes. I think it's incredible. And it all started with Lachlan asking that question, what would make a good day for you? So those are my 4 ands to thrive in this new world. Improve healthcare and improve health. Make those incremental improvements, those marginal gains, find them everywhere, and do radical redesign and audacious change. Think about reducing costs and improving quality. And let's focus our attention on people who are most vulnerable, including people at the start of life and people at the end of life. And I think that's part of our moral test, actually. I really like this quote from Hubert Humphrey. I don't know too much about Hubert Humphrey, to be honest with you. I know he was the vice president under LBJ, and I know he's from Minnesota. And I know from this quote he had a heart. And I don't think our moral test is too different from this, really. To think about those who are in the dawn of life, those who are in the twilight of life, those who are in the shadows of life. And if we did better for them, we'd do better for us, I think. So thank you very much for paying some attention over the last hour or so. And you now get a well-deserved break, and we'll see you back in here at 11:15. Thank you.